Are you ready?
Okay.
All right, here we go. Thank you so much for joining us this morning, this afternoon, this evening, depending on where you're joining us in the world. We've had some excellent questions, and we continue our discussion on transgender health. And I have the pleasure of introducing Dr. Jules Chiton-Brennan. And as a reminder, all our presenters in this continuing medical education activity have indicated that neither they nor their spouse has any financial relationships with commercial interests related to the content of this activity. Dr. Chiton-Brennan is the medical director for the Gender Health Center Trans Health Clinic within the Santa Clara Valley Health System. Previously, trans HIV care and integrated primary care at FQHC setting in the South Bronx, worked in the New York City jails, medical provider, and trans health consultant. Limited trans HIV related research experience, but I don't know, I have seen the deck. I was very impressed by what will be shared with us today. Self-identifies as white, trans, masculine, pronoun preference, they and him. So with that, I'm going to turn over to Dr. Chiton-Brennan, and thank you so much for being here with us, Doctor.
Great, thank you so much for that introduction, and thanks for being here all. So, let's see here. Okay, so by the end of today, I'm hoping that you'll be able to describe what's going on. Okay, so it's kind of got a little rogue here, but let's try this again. So I'm going to be talking to you today about the idea that gender-affirming care is in and of itself HIV care and prevention for trans people. And I'm hoping that by the end of today, you'll be able to describe an HIV first approach to addressing HIV in trans communities and some limitations of that approach. In contrast to that, describe a community first approach to HIV prevention and care for trans people, and name 4 ways that gender affirming care in and of itself serves as HIV prevention and treatment for trans people. So I'm not going to go through the usual list of terms related to transness. I hope you've seen those, but I do want to be on the same page that when I use the term trans, I'm using it in 2 ways: as a preposition, so whatever follows trans is the person's self-identity, and as an umbrella term to encompass the full scope of transgender, non-binary, gender expansive people. And when I say gender affirming care, I'm primarily referring to hormonal care, which is my scope, but it could encompass any of these other kinds of care as well. So just to get us thinking about the intersection of trans communities and HIV, I'm going to talk to you about this project a little later, but I want to pose this question to you. So I worked with a group of trans community leaders in an area of high HIV prevalence, and we worked to define a set of trans health priorities. So of the top 10 priorities, where did HIV rank? So keep your answer in mind, and we'll answer it in a bit. So we couldn't have a talk about trans folks and HIV without pointing out the hugely disproportionate impact of HIV amongst trans communities, particularly amongst trans feminine people of color. So people assigned male at birth identifying as women or other than men of color. In the US, seen rates of up to 25 to 44% of Black African-American trans women living with HIV, up to a quarter of Latinx trans women living with HIV. Less information about trans men, but there's some evidence to say that trans men who have sex with cis men are at higher risk as well. And amongst people living with HIV, trans people make up a disproportionate number. So I unfortunately don't have West Coast data, but in my work in New York, amongst Ryan White funded locations and access to data that I had access to, more than 4% of people were identified as trans, which is much more than the 0.6% estimated that amount that trans people make in the general population. So I think when we're talking about getting to zero for trans people, we really need to start with a paradigm shift. And I would describe the sort of currently accepted paradigm in thinking around HIV and trans folks as going something like this. So our overarching goal is getting to zero. Trans people are a high-risk population and often conceptualized as an extension of MSM communities. And so our questions derived from that are towards our goal of getting to zero, how do we include trans people? And secondarily, how do we get trans people to use our HIV and prevention tools? And this is what I would describe as an HIV first trans inclusion model. So in this model, some of our goals or research questions might be, how do we increase uptake of PrEP amongst trans people? How do we increase adherence to antiretrovirals for trans people? And some of the strategies that might accompany that would be something like having a trans identified outreach worker, maybe, or having representation, visual representations of trans people on our outreach materials. And this is what I would call collectively rebranding. So we're taking our HIV tools and rebranding them to be sort of more accessible to trans communities. So the basic idea here in this model is that the HIV specific goal comes first, and trans people are fit into the HIV context, often as an add-on, again, to MSM communities. And I think there are some deep limitations to this model. I think that becomes most apparent when we think through what are the reasons that there's a high rate of HIV amongst trans folks. And so I know that you saw this model earlier. So this is the gender affirmation framework, and we're lucky enough to have Dr. Sebelius, who created this framework, speak earlier, speaking to the framework for understanding the vulnerability of trans women of color, specifically to HIV. So I won't go into great detail because I'm sure Jay explained this much better than I could. But just to highlight some of the points that will be important to what I'll speak to. So trans folks are, we know, a deeply socially oppressed group that includes things like barriers to healthcare. Social oppression and stigma lead to psychological distress. And so if you're psychologically distressed, there's an increased need for affirmation. If you're trans with psychological distress, you need gender affirmation. And social oppression means we have decreased access to the tools that would allow us to have gender affirmation. So collectively, this picture leads to high-risk context in which ultimately behavior happens that leads to HIV infection. So we're in this framework, and I would say, as a clinician and my experience with community, that this framework resonates, this framework rings true. So if we accept this to be true, where in this framework are the majority of our HIV interventions happening? So I would argue that they're happening here. They're happening quite proximal to HIV infection. And so this is limited for a number of reasons, some of which relate to other communities as well, and some specific to trans community. So firstly, when we're starting here, we're already behind, right? So there's been presumably a lifetime of things that have happened, are still happening, that we're not addressing that perhaps we could have. And again, I think this applies to other communities as well. I would say this is also a missed opportunity, because if we're starting here, not back here, we know that these things don't lead to just high rates of HIV. They also lead to other health disparities, and in particular for trans folks, a 40% lifetime suicide attempt rate. And I would say this in and of itself is an epidemic as well. And so we're missing an opportunity to address those things too. So getting more specific to trans folks, I would say that this is also an incomplete approach, because we're missing the unique challenges and therefore unique opportunities that are specific to trans communities, namely here, gender affirmation, that might greatly impact HIV, vulnerability to HIV and HIV outcomes. So, and I'll take it one step further. So specific to trans folks, in addition to being an incomplete approach because we're not addressing the gender affirmation piece, I would actually argue that this way of thinking, the HIV first trans inclusion approach, is actually further damaging the relationship, which is already tenuous, between healthcare systems and trans communities. And the reason for this is that we're essentially sending the message that trans people are only worthy of the health system's attention and money as we pertain to a public health crisis. And you can see how that sort of perspective or that messaging is backed up by action with funding. So if, historically funding for trans health was pretty much synonymous with HIV funding. You couldn't get funding for trans health that was not tied to HIV funding in some way. So if you look at research funding, it's a study of studies by the NIH, very small number of studies related to trans folks, and vast majority were related to HIV. If we look at funding, both organizations providing funding and recipients of funding, again, vast majority are related to HIV. And these might be a little out of date, but I think still within the context of generational memory of trans communities, and still important in how this framework was laid. So again, sending the message that we're only worthy of the health system's attention as we pertain to HIV, to a public health crisis. So I would argue that instead of the question, in the context of our goal of getting to zero, how do we include trans people, the HIV first trans inclusion approach, that we need to be asking, in the context of health and wellness for trans communities, how do we understand and address the HIV epidemic? And this is what I would call a community first approach. So I'm going to tell you a little bit about a project I completed that helped shape my thinking and language around this topic. So I worked with, this was a community-based participatory research project, and I worked with a group of trans community leaders in the Bronx, New York. And for context, the Bronx is an area of high HIV prevalence, 2% across at baseline. And the project was in the context of the sort of growing interest in trans people over the last few years. How do we develop community-based recommendations for to guide these new efforts and interests? So we convened a group of experts, and here we redefined expert to be people of trans spectrum lived experience, people that were community leaders in different ways, not defined here, and experience with healthcare from different perspectives. So this group went through a formal consensus building process, similar to when Endocrine Society builds expert-based recommendations, and came up with a set of priorities for trans health and wellness ranked 1 to 10. So where do you think HIV ranked? I will tell you. So HIV begrudgingly ranked at all, and it ranked last. And it only ranked with this clarification that the framing had to be that we need HIV care addressing community needs, not numbers, and a recognition that we are, quote, more than our status. Again, pointing out the messaging that has come across that trans people are only worthy of attention as related to HIV. So to give you a sense of some of the other priorities that ranked above HIV, so the first was universal access to gender-affirming care. Some others were economic empowerment, access to gender-affirming mental health and substance use treatment, and importantly, systems of accountability to and leadership by trans community for institutions receiving funding for trans care. And it wasn't that people didn't understand the impact or the importance of HIV. So many people were directly or indirectly impacted by HIV and knew the effects really intimately. But people believed that HIV was a symptom of these other things, and that to really impact HIV, this is where we needed to start. So some of the recommendations from the group were that we needed leadership of trans people. This is in contrast to inclusion, so hiring trans folks at all levels and not just as outreach workers, partnering with trans communities at the very beginning stages of developing any kind of intervention relevant to trans communities. And this is in contrast to rebranding or already preconceived HIV interventions, and funding and support for fundamental trans health needs, again, not tied to HIV. So because I'm a medical provider and this is my scope, and because this was first on the list of priorities, I'm going to try to unpack this first one a little bit in terms of access to gender-affirming care and how this is actually necessary to use our HIV-specific tools and how this leads to improved outcomes. So just to reposition us in our framework here, so by providing gender-affirming care, we've moved away from HIV. We're not as proximal, and we're closer to what we might call root causes. We're addressing barriers to healthcare, we're addressing need for gender affirmation, and some others as well that we'll get into. So I'm going to start with a case. So this was a patient of mine, new patient to me initially, 26-year-old Black woman of trans experience. She came to me to start hormones, and we did start hormones. And on our initial visit, we did some sexual health screening, and she came back positive for gonorrhea. And so I brought up PrEP, it seemed appropriate. And she said, you know, I just don't really think PrEP is for me. I don't really want to deal with all that. And I could tell there was something else behind the statement, but she was sort of sending signals that she didn't really want to talk about it anymore. So what I suspected was behind this, as is behind a lot of statements from many patients, was medical mistrust. And so I know this is true for many individuals I've worked with, and it's true kind of across the board for trans folks, and even more so for trans folks of color. These are statistics from the largest national survey we have of trans folks in the US, nearly 30,000 people, that about a third of people reported a negative experience with a health professional in the past year. About a quarter avoided needed healthcare due to fear of mistreatment, specifically due to trans identity. And so how do we address mistrust? So I would argue, and I know that research backs this up, that an ongoing relationship is key to building trust. And so where does that relationship start? So I don't know if anybody here had a really meaningful ongoing relationship with a medical provider in your transitional age youth years. I know that I had one for only one reason, and that was for gender affirming care. So gender affirming care, I think for a lot of trans folks, is an opportunity to establish a relationship, establish a practice of shared decision making and empowering patients in decision making. So if we come back to our patient, so we're moving forward around the gender affirming care piece. A couple of visits later, she's seeing changes related to hormones. We're speaking more freely. She's very happy about the changes she's seeing. And sexual health comes up again, and she says to me, you know, my trans mother says that I shouldn't take PrEP while I'm on the hormones. So we ended up having a group visit with her trans mother, and she ultimately ended up deciding that PrEP would be right for her. But we wouldn't have gotten this far if we had stopped at PrEP as the goal. And so building the relationship around the gender affirming care piece really allowed for this to happen. So another patient, 19-year-old Latinx trans woman, she'd been on hormones for about a year. She'd been in my care for about 6 months. I had seen her a couple times, but not so often, some missed visits here and there. But at one visit, she was telling me about her sex life, and she described having sex with 2 to 3 cis male partners per week, kind of inconsistent condom use. We treated her a couple times for STIs. She'd actually had a trial of PrEP, which she discontinued on her own due to GI side effects, which I suspected there was something else going on, but she didn't want to troubleshoot. And she repeatedly declined HIV testing. Okay, so at our most recent visit, she expressed some ambivalence to HIV testing. So this is several visits later, we're working together again on the gender affirming care piece, and she kind of broke down and told me, you know, the stigma of being a trans woman is already too much, and I just couldn't handle the stigma of being HIV positive too. She described to me not having supportive friends or family who would blame her because of her quote unquote lifestyle. She felt she'd been throwing her life away, and that depression had delayed her high school graduation, and essentially that she was not worth taking care of. So here we see the effects of stigma, the need for gender affirmation, and the impact of mental and emotional unwellness, depression here, all coming together. And we know that mental distress and mental wellness are strongly linked to HIV outcomes. We also know that gender-affirming care independently on its own decreases depression and increases feelings of self-worth, has a direct impact on mental health for trans folks. And I can tell you, I worked with a lot of people that said, I can honestly say for the first time I want to live, or I can get up in the morning, or I was a shadow before and now I feel like I'm my true self after starting hormones. So it has an impact in and of itself. It's also an opportunity to link people to formal mental emotional health care if gender-affirming care exists. So with this patient, we ultimately decided, she said, I don't know what I would do if the test came back positive. So we decided to develop an emotional health care plan for her, support groups for a more affirming peer experience, and we're awaiting repeat testing and retry of PrEP versus treatment, depending on the test. So another benefit of gender-affirming care is the opportunity to link to other services. So I don't think this model is new in the HIV world, right? In order to be successful with HIV prevention or treatment, we need to have an active desire to live. We need to be able to organize tasks. And in order to do that, it's helpful to know when you're going to sleep at night, right? And again, not new in the HIV world, but I think what's important here is that for trans folks who are seeking gender-affirming care, that this is often a starting point to be able to link people to other services. And I think oftentimes these services are only, the linkage is only made after people have an HIV diagnosis. So this is another way to link people to care. So lastly, I'll point out that for folks living with HIV, having integrated gender-affirming care in HIV is associated with improved outcomes. And that's because reducing practical and, I would argue, emotional barriers to both kinds of care. So we know if people are forced to choose, and that might be due to time or emotional labor, that some people will pick gender-affirming care over HIV care because it is just as, if not more, life-affirming. We know that when these kinds of care are co-located, it increases engagement with HIV care. And we know that gender-affirming care is a predictor for positive HIV care cascade outcomes. So this is a study that I completed looking at HIV care cascade outcomes for trans women living with HIV in the Bronx. And estrogen, we found, was the strongest predictor for retention and care, and ultimately for viral suppression, we think, mediated by retention and care. So to just kind of sum up here, so providing gender-affirming medical care, we're directly increasing access to gender affirmation, we're decreasing barriers to healthcare, we're directly affecting psychological distress. It's an opportunity to link to specific gender-affirming emotional healthcare and to try to address some of these concrete needs as well if you have other kinds of support services in your institution. And all of this is really kind of necessary to ultimately optimize any of the HIV-specific tools that we might use. So in terms of gender-affirming medical care, I would say that this needs to be a starting place and not sort of an add-on to HIV care. And by doing this, we're conveying that we care about patients and their priorities, not just numbers. It's a basis for a longitudinal relationship, which is important to building trust. It directly impacts mental health outcomes and increases self-esteem. It's an opportunity to link to other services, and it reduces practical and emotional barriers to HIV-specific care when these kinds of care are integrated. So in conclusion, I would say that getting to zero for trans communities requires us really to have a paradigm shift from an HIV-first trans inclusion perspective to a community-first approach. And what this would mean is addressing HIV-related barriers and opportunities unique to trans people. So we're talking gender affirmation here, in contrast to the rebranding that I mentioned earlier. We need to be addressing community-centered trans health priorities, not centered on HIV, though we know this will ultimately lead to improved HIV outcomes. Leadership, not inclusion of trans communities, which means funding for and provision of trans health, again, not tied to HIV specifically. And many thanks for having me.
Thank you so much for those insightful words and the research. It's actually fascinating. I have some questions in the chat that's come up. So in reference to the case study that you shared, Doctor, you said that you actually provided PrEP first before thinking about actually doing the HIV test. Is that what was shared?
I'm sorry, say again. So in one of the cases?
Yes, you said that you actually had the person go on PrEP before they actually got tested. Is that what happened?
So no. So the idea was to develop a support plan for this person in order to be tested with kind of contingency plan of either restarting PrEP or treatment, depending on the results of the test.
Oh, very good. Okay. The next question I have here is you made reference to the high level of suicide attempts or thoughts amongst the trans community.
Mm-hmm.
And that's related to HIV as well, meaning that they're more at risk if they have like a low self-esteem, if they don't feel affirmed in their identity. What does the opposite look like when someone is affirmed, someone has a high sense of worth, and they're a productive person in society? So what does a healthy trans person look like?
Yeah, I mean, I think we have countless examples of healthy trans people that are really thriving and doing well. I see many of those folks here in my clinic. So when people feel affirmed, when they feel like they have the support they need, people say, I'm just working on myself right now. And, I realize that maybe my talk was a bit heavy-handed on the sort of potential for negative outcomes. But I think that when all these things fall into place, people are just people, and they're happy, healthy, powerful, prideful people.
Is it worth studying those kind of resiliency or protective factors amongst the transgender community?
Yeah, I think it's absolutely worth studying resilience and having a strength-based perspective. And I would say that, I argue for this community-first perspective because I think that, we need having leadership come from trans communities and partnering with trans communities and empowering trans communities to know what, we need for ourselves and to have the resources to make it happen. I mean, I think that's part of resilience. And I think that's part of understanding that. I think that, we don't know what we don't know. And so I think that we do need to be focusing on community-based strengths and knowledge and building from there.
Excellent, thank you. Another question that came through the chat: what is your biggest challenge in working as a healthcare provider, working specifically with the transgender community?
This is my biggest challenge. I think my biggest challenge is sort of walking a line, that it's something that's deeply personal to me. And it's both brings me so much joy to be able to serve different parts of shared community. And it's also really heartbreaking to see that people have needs that the system is not accommodating. And so I would say that's probably my biggest challenge, is trying to meet needs when the resources aren't always there.
Great, thank you. And my last question, if you can give us a closing comment about what you hope the future will bring us. I mean, we've had an interesting week. We're hoping that we can find change in our communities. And so my question is, can you give us a closing comment about what you hope the future looks like?
What I hope the future looks like is, I hope that, regardless of how the election seems to go, which is scary for trans communities, but there does seem to be an increasing interest in trans people. And I hope that that interest and energy can really be funneled into, as I said, building up the leadership of trans communities to really, design the interventions that people want and need. And that's, again, not just related to HIV, that's related to economic empowerment and education and community building and all these things that I consider to be integral to health and wellness. And I know many people do as well.
Excellent. Well, I want to take a moment to thank you, Dr. and Dr. Sebelius, for being here today with us. It's been wonderful. I learned so much. The people that have been online have had so many questions. And again, thank you for your time and efforts. And I also want to thank Santa Clara County Health Department, the Health Trust, the Pacific AIDS Education and Training Center, and all the people that have been working behind the scenes to make this possible. And with that, I'm going to say goodbye, adios, and good evening, or wherever you're joining us from, because people are joining us from all over the world. And again, thank you so much. And I am going to sign off and thank you.
All right, thank you.